autumn months are fast disappearing and the winter months are coming on us, we are reminded so often about this particular period of the year being described as the flu season. And this is really not by accident. Such is the impact of influenza or flu or common cold or sinusitis or allergic rhinitis that upper respiratory and lower respiratory tract infections become one of the major reasons as to why people get sick. They spend days and hours in physicians' offices. They miss lengthy periods from work. They spread infections within their households. Children miss days off school based on lower and upper respiratory tract infections. Also end up infecting each other in classrooms, so that sometimes you lose many hours of working time, productive time that should be spent on improving the economy and also providing a living for those that need it the most. It also impacts on our children in school and them not being able to function at a level had it not been for the fact that these infections are so common. I was very elated a few weeks ago when I saw a movie by the name of, I think, Contagious. I've always been trying to educate the patients in my practice as to what is influenza, because every time I insist on them taking the influenza vaccine, I sense sometimes I feel a sense of resistance from them when they mention, well, I've never had influenza before, and I've never taken the flu vaccine before, and I've never gotten sick before, and I basically do not need the influenza vaccine. And I shake off my cough and cold in about 2 to 3 days and I'm back to work. Or I've taken the influenza vaccine before and I felt sick because of it. Or I really don't think I need it. I think it's something being played up by the media or the medical community as not being as serious a disease as they make influenza out to be. But I've got news for you. The movie Contagious really in fact depicts what influenza is really like. Influenza per se is not common cold. It's much, much different. For those of us who have had dengue fever, it's closer to dengue fever. It's closer to some of the symptoms some of us who've had malaria before, or yellow fever, with bone-breaking illnesses, headaches, fevers for weeks on end. Influenza got its notoriety from the fact of the number of deaths it actually caused. The incidence of morbidity and mortality associated with influenza has actually been documented as having caused millions of deaths. In fact, one of the things that I was surprised in medical school to read that in 1940 it actually wiped out almost 20 million lives. The issue about this influenza virus is that there's no way to predict when it's actually going to be causing that degree of morbidity and mortality. We all got scared the last time with the swine flu, when people who got it die almost within hours. But my advice is, if you get a chance to look at this movie, it tells you how a respiratory tract infection can spread so easily. It probably is a little bit more than we expect to find for influenza in the rapidity in which it causes death. But the morbidity associated with it, and the way in which it spread, and the methods of trying to contain it, once you actually discover that you've got it, it gives you an idea as to what a real contagious disease influenza could be, or other contagious disease that are spread from the upper respiratory to the lower respiratory tract. The reason for me telling you this is that I want to at least advise you that you are aware that the influenza vaccine should not be taken lightly. Every year there's a different vaccine, and it's based on 2 enzymes, hemagglutidase and neuraminidase. which are found in the capsule of the virus, influenza virus. And by a method of predicting the way in which it actually has replicated over the years, scientists, virologists in particular, have called in on a method of finding out or seeing the chances, or statistically, what is the influenza virus based on the H and the N that is going to be affecting us, or most likely to affect us. It doesn't mean all the time they have to be as accurate as saying every viral infection caused by influenza is going to have these two enzymes, the H1, the N1, or whatever strain of H1N1. This is totally different from swine flu virus. This is a virus that's basically spread by humans. Swine flu is a virus that replicated in swines that can actually be transmitted to humans and replicate within humans. So it can also be monkey viruses for other infections. Viruses that tend to grow much more rapidly in animals, but were able now to be transferred to human beings. In the case of influenza virus, my reason for telling you this is that basically you understand that there's a need for taking the vaccine. There's a reason why there's so much hype on it based on the real facts of the increasing morbidity and mortality. From a historic perspective, that has caused millions of deaths. And to get a fair idea as to how it impacts in terms of the spread of it, in addition to that, it's how it actually affects your own being in terms of how you have to try and prevent others from spreading it to you. Maybe it's done in a theatrical sense that makes it much more appealing to us as viewers, but it's not very different when you're faced with death and dying in your own family based on the fact of having a very contagious disease. To put influenza back into perspective, and the perspective of those patients who I've encountered over the years in my practice in Richmond Hill, is to understand that common cold, the difference between common cold and influenza. Common cold is an upper respiratory tract infection that lasts for 2 to 3 days, associated with some mild headaches, dehydration, productive cough, maybe itchy eyes, running nose, and a clear mucoid discharge. In addition to that, sometimes a yellow discharge if it's associated with the shedding of the lining of the nasal passages and the upper respiratory tract. It can also be associated with mild bronchospasms as the infection spreads into the trachea. It can actually cause a laryngitis if it involves the vocal cords, and also can be associated with mild bronchitic symptoms. If you want to make a simplistic approach as to what influenza is just to imagine that you make common cold 10 times worse. And that is my perspective of looking at it. I've never heard it described as this, but this is the way I think if I explain it to patients. Think about the headaches you get in common cold and multiply it by 10 times, that's what you get for influenza. But in this diagram, we'll try and describe pictorially what goes on with influenza virus. This is actually a representation of what the influenza virus looks like. And basically it replicates itself numerous times, but it also has these projections on the outside that makes it so much nicer and so much easier for it to stick to the upper respiratory tract epithelium. And influenza spreads by little droplets. Obviously, when we cough or we sneeze, the droplets themselves spread rapidly into the atmosphere. And if the humidity is appropriate enough, especially sitting in a waiting area and you're close enough to someone, it's also like a trajectory motion that you could actually pass it on to someone who nicely breathes in that, and then it attaches to that unsuspecting person's upper respiratory tract. So I'm carrying the influenza virus. I'm in my doctor's waiting room or in my living room with the other members of my family. I sneeze, the droplets spread, then the other relative who's sitting next to me, or the other patient who's sitting next to me, or the worker in my office who is sitting next to me, breathes it in very nicely, and it gets attached to the mucosal epithelium of the nasal passages. By breathing in the air, you take the virus, the influenza virus, into your upper respiratory tract, into the the posterior aspect of the oropharynx, and then you bring it nicely into the lungs. And I will discuss the different areas that are affected and how it actually replicates, attaches to the respiratory epithelium, and then forms a focus of infection, which then spreads into the bloodstream and then spread to the other organs, including the brain. When we think of the symptoms, I'll go through the body parts that are affected, and you'll see exactly how you get infected by that virus. When we look at who are the persons who are especially at risk, it's the same like in most infections. Those of us who are over the ages of 65 and older, those of us who are immunocompromised, whether by HIV, cancers, or other chronic infections, including diabetes, pregnant women, and also children between the ages of 6 months and 23 months. The influenza virus, the influenza vaccine, which is a live attenuated vaccine, which means when you get it, you cannot get influenza as a disease process. What you get is a subclinical infection of influenza, which then makes you produce the antibodies. So when you get exposed to that strain of the virus, then you do not get the full-blown influenza. It also, even if you get exposed to a different strain of influenza virus, it decreases the signs and symptoms of a full-blown influenza infection. The flu vaccine or the flu shot is given every year, and every year it's a different vaccine. So at any time you're getting the vaccine, always make sure on the bottle itself or on the box itself, it says, at least for this year, 2011 to 2012. Last year's vaccine is no good, and the previous years are no good either. The issue of that, you have to get the vaccine for that particular year. And the vaccine is usually given on the shoulders, on the deltoid muscles, and it lasts for the entire flu season. The influenza vaccine, it says it's obviously done in terms of actually being the predictor of that strain of influenza virus for that year. But no means is it 100% that it's going to be targeting that influenza strain virus that we expect to be associated with a tremendous amount of morbidity and mortality. But it at least gives you a fighting chance. Is there tablets to be used? Yes, tablets can be used to treat influenza illnesses. But sometimes it's probably a little bit too late by the time we start using the tablets. But the tablets themselves can actually decrease the signs and symptoms associated with the influenza virus, whether it be the headaches, the bronchitis, and the other target organs that are affected. What are some of the complications of influenza? When we go back again to the etiology and the pathogenesis and the clinical manifestations of influenza virus, we're looking at the way it spread into the upper respiratory tract, into the nasal mucosa, back and down to the oropharynx, then into the trachea, where it can involve the vocal cords, then into the trachea and the bronchus, and into the bronchioles. When it spreads into the upper respiratory tract, then it spreads by viremic spread into the bloodstream. When it spreads into the bloodstream, then it can be circulated to the brain itself and is associated with a severe headache. And it's nothing similar to the headaches that you can get with a common cold. These are worst headaches you've ever had in your life. And for those of us who have ever had a dengue fever, it is similar to the headaches you get, which last for days and sometimes for weeks. And even after the headaches are gone, it's always associated with a period of time where you're unable to absorb or remember as much as you were before you had the infection. And that in itself sometimes makes a person feel very helpless, that they do not feel as if they're focusing as much as they were able to do before. And sometimes kids who are affected by influenza usually do not perform too well in school weeks after the influenza illness, especially a full-blown infection with the influenza virus. We also associate with a headache, a severe fever, and that fever is usually between 102 to 104 degrees, which is extremely high, or close to 40 degrees centigrade. In that case, even in the common antipyretics, the Panadol, the Tylenol, do not even have an impact on the headaches. You'll be taking it almost every 2 to 3 hours just to be able to get rid of the fever and the headaches. The fatigue and the weakness that's associated with the viremic spread when it spreads into the bloodstream lasts for 2 to 3 weeks. This is not a common cold where we after 2 to 3 days we are shedding the symptoms, we're back to work, we feel good. In influenza, the symptoms of it last for 2 to 3 weeks. Think again of dengue fever. Think again of things like yellow fever and malaria, in which you feel the illness, the fatigue, and the weakness goes on for weeks on end. And that is what we experience in influenza. We do get the upper respiratory tract symptoms, which are the cough, the cold, the itchy eyes, the running nose. As the virus invades the mucosal epithelium, it definitely causes the shedding of that mucosal epithelium, similar to any upper respiratory tract infection. But in this case, because of the lengthy period of time it infects the upper respiratory tract and the lower respiratory tract, it's associated with a much more florid discharge from the respiratory epithelium through the nasal passages. Also can infect the sinuses associated with maxillary sinusitis, frontal sinusitis, ethmoidal sinusitis within the ethmoid sinus of the brain. And it usually can sometimes be a very terrible illness to carry for weeks on end. At the same time, the sneezing and the sore throat can sometimes make it a little bit more difficult in terms of treatment. The coughing aspect, as it irritates the posterior nasopharynx and the oropharynx, produces that trend of spreading it widely, and it is such a virus that sticks to the epithelium so rapidly. The good thing about it, this virus does not survive outside of the body for too long, but such is the nature of the spread of it in terms of persons sitting together, how easy it is to spread, either by the types of way it can spread is by contiguous spread. Me having it on my respiratory epithelium, I blow my nose, I shake your hand, you rub your nose, you're getting it. Also the fact of I'm having it, I go to the bathroom, you go there a few minutes after, a few seconds after, you're taking the virus into your hands itself, and that's how it spreads. So the simple methods of washing your hands, avoiding doorknobs, not to be coughing in people's face, to avoid all persons at all costs, to try and prevent the spread of it is one of the golden rules associated with any upper respiratory tract infection, but much more so for something as contagious as influenza. And some of the simple things that we always do with a contagious infection, of washing your hands, be aware of those around us. When we sneeze into our handkerchief, trying to avoid those who are sneezing, trying to avoid exposure to those who have it. Some of the ways of dealing with it, trying to get some rest, avoid alcohol and cigarette smoking, avoid crowded places when we have upper respiratory tract infections, regardless or not if we know if it's influenza or any other form of common cold or other viral infections. When we look at the risk factors that we face with, not only can we get a cough and a cold associated with an upper respiratory tract, we can also get a bronchitis associated with it, and the bronchitic symptoms can last for several weeks. The upper respiratory tract associated with the cough, cold, fever, chills, and productive sputum. The lower respiratory tract associated with severe discomfort of the chest, productive of a greenish sputum. And here again, there's no need for antibiotic to treat it, but a lot of times, as in a lot of viral infections, there's a secondary bacterial infection that can be caused by the fact that the virus causes the immune system of the host to deteriorate to the point in which a secondary bacterial infection can now invade the bronchus and the bronchioles, and now you have to treat that person as if it's a bacterial infection. But the role of the antibiotic has nothing to do with the virus. It has to do with a secondary bacterial infection if your doctor so desires to treat. But I guess these are things that need to be explained to you. So the method, the education here for the patients of mine and for those who are listening as well, is to understand fully well as we approach the flu season or the influenza season, that influenza, unlike a lot of us that we tend to believe, is not like a common cold. It's a much more serious illness. It's a serious illness that's given a lot of attention by the media, because those who have experienced epidemics of influenza, and I really think the last epidemic was probably about 15-20 years ago. So those of the healthcare professionals who know about that epidemic are very cognizant of the fact, and the CDC is very much aware of the deaths associated with influenza outbreaks and influenza pandemic, and how it affects global trafficking, global travel. That basically an influenza outbreak in Hong Kong creates as much a dilemma in Arkansas because of the simple fact of the simple way that people travel. And by travel, then we have to go and isolate where was the source from, who was the one spreading it. If so, we all listen to the media when you have these outbreaks that have taken place with swine flu. Then you had the last outbreak that we had with so many persons in Hong Kong being affected by this particular strain of a virus. So it's always important that we follow simple guidelines and do not think that as physicians we're here to misrepresent what the truth about influenza or any other diseases, because there's really nothing to be gained by that. Neither does the media have a reason for hyping things that are insignificant. Usually they will hype things that carry some degree of significance. And here again, sometimes it's better to be safe than to be sorry. Ignorance is no excuse for us to ignore the facts. If we know the facts and decide to ignore them, like decide that we do not want the influenza vaccine, so be it, but at least make sure you understand the implication that if there is an outbreak, at least try and make sure you try and get the vaccine as fast as you can, if it is available. If it's not available, tough luck. You had the choice to make when it was available. For those of us who are over the age of 65, immunocompromised, and kids between the ages of 6 months to 23 months, it's definitive that basically because of your immune system, you will benefit from getting influenza vaccine. But here again, it's not my word that counts. You can speak to your physician as well and find out what are their thoughts on it. And even more so is to find out what the general thoughts of those around you are. As regarding the spread and the degree of contagiousness of this of influenza, this is not for me to describe to you. We all have experienced the spread of common cold and other viral infections, or red eye and pink eye, or other viral infections, and we all know fully well how easy it is to spread. So the golden lesson here is to educate yourself as much as you can as the influenza season approaches, as other upper respiratory tract where the winter months approaches, and try and prevent it at all costs. If there is a vaccination as an influenza that's available, then we make sure that we either make a learned attempt to, at least if we decide not to have it, what are the methods we will try and adopt if in fact we are faced with an infection, an outbreak of influenza. In addition to that, other contagious diseases we will treat the same way, trying to avoid those who are carrying the virus, trying to do the best we can to observe proper hygiene of washing our hands, not spreading it on doorknobs, using paper towels, disposable paper towels, not to let ourselves be coughing into pieces of cloth and then having it around so others can be touching it. So it's sometimes a very common sense approach to a very serious illness can actually decrease the incidence and the prevalence of these illnesses. We continue our discourse on upper respiratory tract infections, particularly the common cold and influenza. Here again, it's not for us to get it right at all times by saying every nasal discharge or every headache or every sinusitis, every little bit of bronchial secretion, it's either common cold or it's influenza or some other virus. It's for us to understand that if the symptoms are persisting, let's say for argument's sake, today we happen to have a headache. Is that headache due to the headaches due to the fact of our migraine, or is it after long hours of work? Is it tension headaches, etc.? Or is it part of an infection that is now starting? Could it be the prodromal symptom of an upper respiratory tract infection? If we are aware that this is the way some of these diseases present themselves, then it makes it so much more easy for us to put it in perspective. And the purpose of this discussion is for us to be able to put common cold and influenza into a perspective of some of the more common symptoms associated with upper and lower respiratory tract infections. All of us are very much aware that when we have a common cold, we usually get the redness of the eyes, itchy eyes, the nasal discharges, sometimes a little bit of a sore throat, sometimes we even feel a fullness in the ear, and sometimes even feel deafness. Sometimes we feel as if we're in an aircraft that's about to land, and the fullness in the ear. We also, some of us who are prone to things like asthma and chronic obstructive pulmonary disease, start to have difficulty breathing and feeling as if the bronchitic or the wheezing symptoms are coming on. These are some of the things that we tend to feel. The aches and pains associated with the myalgias of any viral infections we tend to feel. But to understand the bigger differences, is this part of our common cold which is going to last for 2 to 3 days, or is this a bigger picture of something much more serious like influenza or any other diseases that presents with its long prodromal symptoms for 2 to 3 weeks that is going to result in a prolonged period of morbidity and can even be associated with mortality in those of us who are probably predisposed to infections because our immune system is compromised for one reason or the other. So it's important for us to know what some of these common symptoms are, just for us to know that this is not just the headaches that I'm getting because I worked for 8 hours with my boss who's still unappreciative even if I give him everything I can. Or is it the headaches due to the fact that my child has been sick for the last day and also has an upper respiratory tract infection and came home with a pink eye? Is this now part of a general picture of a contagious disease that I can now pass on to the rest of the household? And if so, how do I prevent it? Or should I go by my doctor and have him examine my child to make sure that he or she does not have the illness that we're talking about, and also make sure that I can take the precautions of preventing myself from getting it so I do not miss long hours away from work, long days away from work, and my child does not end up missing days away from school. When we look at some of the parts of the bodies being affected, we all are aware that this is the head with the nose and the oropharynx that leads through the trachea into the bronchus. But let's look at the head, and the frontal sinus at the very top of the head here usually can be infected with a fluid, and we feel this heaviness in the head itself. In addition to that, we also can see another diagram with the frontal sinuses here, which can show this is the frontal sinus, this is the maxillary sinus, and when we get these headaches, they're usually severe headaches, throbbing headaches at the top of the head, especially when they're being infected, or facial pain associated with maxillary sinusitis. And we also have the drainage from the through the medial, the upper and the upper, middle, and lower nasal conchae that actually forms these secretions that tend to come out. In addition to that, we have the rest of the oropharynx, the nasopharynx, the oropharynx. But this is the opening of the eustachian tube. And that opening of the eustachian tube, if all the areas around here are actually being infected, the opening of the eustachian tube actually is the connection of the inner ear with the back of the throat. So a lot of times when we get infections involving the oropharynx and the nasopharynx that causes a blockage of the eustachian tube, they actually predispose us to have an infection within the middle ear. When we have that infection, now we become deaf, we are unable to hear. And in addition to that, we have this heaviness in the ear itself associated with fevers, severe worsening headaches, and deafness. This is the case when we have the middle ear being infected. This can actually cause pus within the middle ear. Now there's no fluid that can actually drain into the eustachian tube because this area through which it opens into the back of the throat is usually blocked. There's only one way this infection can now be drained, is when it ruptures the tympanic membrane, creating a hole within the tympanic membrane, and that's how we can get the deafness associated with a middle ear infection caused by an upper respiratory tract infection. So when your child or you complain of the headaches, earaches, It's not their imagination. Basically, we know very easily what causes the headaches. The fluid within the closed sinuses, the frontal sinus, maxillary sinus, the ethmoidal sinuses, sphenoidal sinuses, can all cause the headaches within that area of the brain, within that area of the skull itself. We know what causes the nasal discharge as the infected respiratory epithelium on the lateral aspect of the nose and forming the conchae, the middle nasal conchae, the superior and inferior nasal conchae. As they become infected, we have the mucosal epithelium being sloughed off, and this causes the yellowness associated with it, and sometimes even a secondary bacterial infection in a chronic sinusitis can cause discoloration. We know what causes a sore throat at the back of the oropharynx because of the infection and the edema associated with this. We also can get the hoarseness when we have the vocal cords becoming infected. Now we have the patient who now presents with the fact of the bronchus being infected will now have bronchoconstriction, and those of us who are prone to developing signs and symptoms associated with wheezing, whether it be from chronic obstructive pulmonary disease or also from asthma, will feel the bronchospasm or the tightness within the chest. As this infection spread into the bronchioles, we all can see now when the bronchioles become infected, the lumen of the bronchioles, let's say that this is an open airway. Now when it becomes inflamed, the muscle can undergo bronchoconstriction and it narrows. But we also get the mucosal edema with the inflammatory process now becoming thickened. So we can see where the mucosal lining is thickened. Now we can see where the mucus within the lumen of an already constricted area can result in even more difficulty breathing. So that's a patient who presented with difficulty in even getting air into the airways, and that's how we can precipitate worsening of pulmonary symptoms associated with chronic obstructive pulmonary disease. We see here the narrower the airways get as we go to the extremities of the lungs, to the distal extremities of the lungs. The airways become much more narrow and much more easily for them to undergo total bronchoconstriction, and for us not to be able to have aeration of the lungs, because it's the alveoli, the most distal portion of the bronchial tree, that actually where the gas exchange takes place. And if there's no air getting into it, we will have difficulty breathing with very little air getting in and out of the lungs, and actually to the stage we can go into respiratory failure in those of us who are at risk for having it. I mentioned to you the ear infection that we can get. It usually starts with the fluid within the ear. Now you can see that this is the malleus, the incus, and the stapes. Air comes into the external auditory meatus, actually cause the vibration of the tympanic membrane. Now this is amplified through the malleus, the incus, and the stapes, which are three bones within the middle ear, and then that is translated into the ear, or the movement of it is translated in the sound. Now when it's filled with fluid, there's nothing can be translated any longer. This is now resulting in deafness of that individual. But as if deafness was not enough for you, when the fluid becomes in a closed compartment, becomes so much so that it's not able to go anywhere, then because of the increasing pressure, the only way it can go, because the rest of here is just skull with the opening of the airway, then it ruptures into the tympanic membrane. We get the running ears, and now we get a relief of the symptoms, but then the deafness will now start because the fact of that opening within the tympanic membrane remains there. At all times, we try to protect the tympanic membrane and treat this as fast as we possibly can. In the case in which subsequent to a bacterial middle ear infection, you will get thickening of the tympanic membrane. It's going to appear as if it's bulging, and it's going to lose its mobility. So the ability to transmit impulses or movements or air movements into these three bones, which amplifies the sound, is then resulting in deafness probably for the better part of our lives. Is that deafness recoverable? Very unlikely so. So the golden rule here is, again, at all times to try and prevent the secondary middle ear infections. We also know how we're going to try and prevent the infection of the bronchioles and infection of the bronchus itself, and prevention of pneumonia. Here again, the methods that I've mentioned before, in any upper respiratory tract or lower respiratory tract infection, we always were trying to prevent them from happening. The most important thing to realize in upper respiratory tract infection is to know when it is that these infections are really upper respiratory tract infections as opposed to symptoms that are totally unrelated to any viral infection. In the next discussion, we will try and describe other lower respiratory tract, other lung disease, other upper respiratory tract infections that mimic these very contagious disease processes. As we continue our discussion regarding upper respiratory tract infection, influenza, parainfluenza, common cold, allergic conjunctivitis, sinusitis, tracheitis, laryngitis, bronchitis, etc. We can allude to middle ear infections, which are much more common in the children and in the school, the primary schools. And for us to understand a little bit more about what ear infections are and how an upper respiratory tract can predispose a child to having an ear infection. The anatomy of the ear canal in an adult is a little bit different from that in a child, in which we can look at the ear itself and how is it the anatomy of a normal ear, first of all, and then look at the pathology that tends to affect us as we get infections involving the ear. We all can recognize this as being the auricle or the external ear, which has its helix to amplify sound and to capture sound and take it through a series of amplification as it goes through the eustachian tube. The eustachian tube, this is portion of the external ear. The tympanic membrane separates the external ear from the middle ear. And this is a tympanic membrane. That's a thin membrane that moves up and down with sound, with vibrations that come into the ear, the sound vibrations. This is further amplified by the malleus, incus, and stapes, which are the three bones within the middle ear that tends to amplify the sound. This sound then through the stapes is then translated into a format in terms of when it actually causes the vibration of the sounds to cause the vibration within the hair cells of the inner ear. So we have the malleus, incus, and stapes impinging on the inner ear itself, in which it goes through the hair cells, and then that is translated into sound, which goes to the brain, into the nucleus of the brain, and basically that's how we amplify sound. Translates into an amplification process that is translated through the inner ear and then gets sent to the brain for interpretation. And that's how we recognize after a period of time of hearing noises, sounds, and then it becomes amplified to the brain. It's a lot more detailed and involved with the vestibulocochlear system, but I think at this point in time we don't need to go that way. We need to see how it has affected us in terms of illnesses that we as patients in a community tend to see. The inner ear or the middle ear is the pressure that allows us to hear, is the pressure in the tympanic membrane is equalized by the pressure within the oropharynx or the nasopharynx through which the eustachian tube drains. So the pressure from the throat itself, because this tube is always kept open, and then the pressure from the external ear and through the eustachian tube causes the tympanic membrane to experience atmospheric pressure. Now, in the event of having an upper respiratory tract infection in which the eustachian tube is closed because of the fact that back of the throat, this is, let's say, the back of the throat here, is infected. Now, the pressure within the middle ear makes you feel as if it's a negative pressure within, as if you're in an aircraft which is landing, and you feel the fullness within the head. And that fullness prevents us from hearing. So anytime we get an ear infection in which the eustachian tube is collapsed, then we need to find a way of opening up it. It cannot be opened surgically in the case of an infection. Sometimes we have to give a medication that can decongest the eustachian tube, and then again that allows us to hear, because the pressure on each side is now on the tympanic membrane, can actually cause vibration of sounds to be translated into impulses when we can interpret and hear. In the event of us having an infection within the middle ear, these bones, these ossicles, tend to fuse, or now they're caught within a watery medium, so they cannot amplify sound any longer. So then we experience the deafness of it. So here again, when we have an infection within this, we can have an infection which is bacterial in origin, which tends, because of the bacteria growing, tends to cause a buildup of pressure within the middle ear, and that can cause deafness within, fever and chills associated with acute otitis media, in which we have the earache, the fever, hearing loss, and when it perforates the tympanic membrane because the pressure is too much within the middle ear, then we get the discharge coming from the ear. And a lot of times as kids growing up, I've seen kids in school who used to have running ears and resulting in chronic deafness for the rest of their life. These are the same infections that can actually spread to involve the brain, and actually a young child that cause meningitis, which is an inflammation involving the lining of the brain that can cause mental retardation as we get older. Because of the pressure within the middle ear, we also can experience symptoms of nausea and vomiting, and with younger children, obviously diarrhea, loss of appetite, and increased irritability. In a child who is breastfeeding that has an ear infection, you will find every time they go and try to breastfeed, because of the negative pressure or the pressure that they have to exert to be able to get milk out of the breast, experience a severe earache and sometimes refuse to feed totally. And that's one of the common things in children, in young infants, is the fact of the loss of appetite anytime they get a viral infection, a viral upper respiratory tract infection that is associated with loss of appetite and inability, irritability, and not even wanting to feed. Here again, the primary treatment of choice is to treat the ear infection with antibiotics. Sometimes we can have a resolving ear infection that results without fluid within the middle ear, which is known as an effusion, and that effusion probably can sometimes result in deafness, especially if it's a tense effusion. And sometimes in kids we see them with these small tubes that drain, that the ear, nose and throat specialists insert into the tympanic membrane to allow the fluid within the middle ear to drain as well. Looking at the general picture of where the ear infections, if we look at the ear, this is the external auditory canal, the middle ear, the connection between the eustachian tube and the oropharynx. We can see where an upper respiratory tract infection associated with sinusitis, maxillary sinusitis, and a throat infection can actually cause us to develop a middle ear infection. How important it is for us to have the eustachian tube wide open so it allows the pressure on both sides to equilibrate, and also to try and avoid obstructions that occur within the eustachian tube. Here is a situation in which the pressure was so high within the middle ear that actually now the middle ear is ruptured, and now there's pus that's flowing through the ear itself. That in itself, as a result of the pressure within, can actually cause deafness for the better part of our life. So what I'm trying to relate to you is the way in which viral infections, upper respiratory tract infection, do relate to ear infections, and they all occur together. The times, it doesn't mean that every time you have a viral infection involving the sinuses that you will get an ear infection. But it's so easy to get an ear infection, especially in the younger school-age kids, that we should always be aware that every time they complain of an earache, is to at least make sure that the ears are being examined. Because an ear infection, whether viral or bacterial, if treated early, can prevent deafness. In the younger children, a child who is not feeding with a nasal discharge, obviously the pediatrician must be checking for an ear infection as well, because an ear infection that can actually spread to involve the meninges of the brain, especially in the younger children. In the elderly persons, especially those who are immunocompromised, we also expect to have this much more common than it is for the average person who is healthy and strong. Many times when patients think about allergies, The majority of times they figure this has to do with, I've got allergies, so my nose is running, my eyes are itchy, I've got a postnasal drip. But this is only one type of allergy. There's several forms of allergies which we will describe. And sometimes we need to figure that when we're experiencing allergies that is caused by an upper respiratory tract infection, there are also allergies associated with skin, allergic reaction to some medication, some way in which we have swelling involving the entire skin, or a rash as well that are actually caused by the same immune system that produces this allergic reaction or allergies. How do we actually have allergies, and what is actually an allergy? An allergy is when the body is exposed to a normal substance but has an abnormal response. By that I mean sometimes we eat seafood, and the body's response to seafood for a person who's allergic to seafood is swelling of the lips, itchiness, swelling around the lips, and even rash on the entire skin as the allergen spreads to involve the bloodstream. That same individual can have bronchoconstriction, resulting in narrowing of the airways, the bronchoconstriction, and difficulty breathing. So allergies and allergic reaction are interconnected. But if we see where the commonality is, that it's probably much more easy for us to take the step from describing doctor I have allergies and only thinking that it comes from the upper respiratory tract, and take that even further to the other end of the spectrum when sometimes patients come to me and say to me, "Doctor, my physician has given me a wrong medication and I develop an allergic reaction." It is not that the physician gave you a wrong medication. It is that you did develop an allergic reaction to a medication through to the same process that caused you to develop allergy symptoms. Meaning that something that's supposed to be causing no response cause an allergenic response to you, resulting in an allergic reaction. If we look at these are some of the ways we can think about allergies, and the most common that we actually experience as patients is the allergic rhinitis with a hay fever and exposure to things like ragweed and pollen. We go to the park to play either a game of cricket, then we get the stuffiness of the nose, itchy eyes, running nose, the sneezing, etc. Irritation and itchiness at the back of the throat, and sometimes the stuffiness and the blocked nostrils as well. Further infection within the upper respiratory tract can result in the sinusitis with the sinus themselves, whether it be the frontal, the maxillary, the sphenoidal or ethmoidal sinuses. The lining around the sinus inside, which is the respiratory epithelium, becomes inflamed and also produces fluid within that closed cavity. And because it's a closed cavity within the skull, there's no way for it to drain, and basically results in a lot of facial pressure, whether it be the frontal sinus, the facial pressure over the forehead, or maxillary sinuses with stuffiness and facial pain. In cases of the nasal congestion around the area, you can also lose your sense of smell. Another form of allergies can be the same child who goes to school and has this chronic rash, or the eczema, a form of atopic dermatitis that tends to be exacerbated by exposure to something that they're allergic to, or to some common form of allergen. And these kind of conditions can be treated quite easily, but a lot of times I find in our practice we allow our kids to go for days or weeks without treatment. What tends to happen, that little area in which you have the atopic dermatitis, now because of the fact of the increased itching around the areas, the child then scratches that area, it becomes inflamed, and the ear becomes infected and even start to weep on its own. And a lot of times your patients describe it as they cannot resist but scratching it. And that is what caused that little area of atopic dermatitis to become extremely inflamed and darkened. And sometimes it's difficult to get rid of the discoloration. A lot of times the itchiness and the red rashes is the time when it should be treated to avoid us from developing the chronicity and the discoloration the scaling and the flaking that sometimes are caused. A lot of times we find that our kids have it on the elbows, on their knees, on the hands itself, on the dorsum of the hands itself, and sometimes it does not look very appealing. And my advice to you is the minute you see the rashes start to appear, at least contact your doctor. It's so easy to treat early in the infection rather than trying to get rid of the discoloration that arises afterwards. A lot of us know of hives, which are the redness and discoloration of the skin, also associated with something called Nikolsky phenomena, in which you can scratch your skin and you can see the redness of the erythema over the area in which the scratches appear. But the allergic reaction is the bumpiness that occurs throughout the entire skin, and most of us would have had an allergic reaction to something. It causes the skin to become inflamed, red, hot, and very itchy. And sometimes we on our own will take a Benadryl, but sometimes we don't always get the response we're looking for. But imagine that same swelling that occurs on the epidermis of the skin can also occur within the airways because of the fact of the bronchoconstriction of the airways and the mucosal edema of the airways. Now you can have a difficult, especially in that patient who is asthmatic or prone to asthma. Now the bronchoconstriction of the airways as well as the fluid within the airways can actually cause that person to start wheezing, developing tightness of the chest. And if you're exposed to enough allergen, I've seen cases in which patients go into respiratory failure and respiratory arrest based on severe bronchitic constriction. And most of us would have seen in movies as well, sometimes patients, players who probably get allergic reaction can actually die from respiratory failure or severe bronchitis or severe asthmatic attack, in which it's difficult or needs immediate treatment. In the case of contact dermatitis, this is a case in which you have inflammation of the skin that's caused by direct contact with an irritating or allergic substance such as poison ivy. And a lot of times we see, or even latex gloves, a lot of times we see these patients when they present with the redness and erythema over the area, and it causes a lot of redness, itching, swelling. And for those of us who decide not to seek treatment, we have the weeping of the skin and rash and the redness of the skin, and then afterwards sometimes we even get a secondary bacterial infection when we decide to engage in scratching it on a regular basis, or sometimes we use a comb and try and scratch it and see how best we can get rid of the itching. That only compounds it even further, because then we transfer it from being just an epidermal infection to a dermal infection, and then it can spread to involve the bloodstream. Many of us who have kids would have at least some instance in which they come home from school with red eyes, or those of us in the workplace exposed to pink eyes from other employees will have the allergic conjunctivitis, in which we get the redness within the conjunctiva of the eye itself, and you actually get blurring of the vision, but you also get the swollen conjunctiva, and then you could actually see the blood vessels running through the conjunctiva. Inside that's associated with redness, itchiness, and watering of the eyes. But that's the same infection. The notoriety of it is basically the fact because it's such an itchy condition, most of us will engage in habits of trying to scratch the eyes, then shake the hands of someone else who then scratch their eyes, and then we pass it on to numerous other persons. Then we have a pink eye outbreak. And it's common in schools, especially they're approaching the winter months, for us to have pink eye outbreaks or red eye outbreaks, which could very well be avoided. Most of us will probably, as I described earlier, allergic reaction to things like peanuts and shrimp, etc., in which you have swelling of the lips, throat and face and the tongue, associated with upset stomach, nauseousness and vomiting, and abdominal cramp associated with the hives and the rash. The hives around the lips and around the face we tend to see. What we don't see is the person who's got the nausea and the vomiting due to the vasovagal response that's happening at the same time, and that person's relief sometimes comes by only vomiting. But the worst effect of this is the bronchoconstriction of the airway, and the most life-threatening part of an food allergic reaction. The same applies to drug allergies, and a lot of us would have had relatives who've had allergies, allergic reaction to medication, sometimes more commonly things like penicillin. And in that case, large doses given to them can even cause death to an individual who is given a drug that they can be allergic to. My advice to you, if you find that you're allergic to a medication given to you and you've had a near death experience, is to always have a bracelet that says you're allergic to this particular medication. Because a lot of times in emergencies, the first place a patient who comes in comatose, the physician will look at the neck of the patient to see if they have a bracelet that says that they're allergic to a particular kind of medication. So it may be life-saving for you. In the case of my sister who developed an allergic reaction to penicillin and almost died from it, was one of the reasons why I'm insisting that at all times you should have that, or have some piece of paper that says that you're allergic to a particular medication, especially common medications that are given. A lot of us are experienced from dust mites and house mites, from the pillows and mattresses, we can develop allergic reactions. And these allergic reactions can result in us having itching of the skin or vague itchiness at different points in time. A lot of times we can actually be accused of being into other places of sleep, other places to sleep, when we develop these rashes and itches associated with house dust mites and other microscopic organisms that burrow in the sheets. What I've tried to do is to explain some of the common infections that we see at this time of the year and put it into perspective in terms of the biggest one being influenza vaccine, influenza viral infection, how it is that influenza can mimic something as simple as common cold, which is self-limiting, lasting to 2 to 3 days. Maximum period of work is probably 4 to 5 days, as opposed to something like influenza. If it does become an outbreak, how do we prevent it? How do we try and prevent it before it reaches the stage of an outbreak? In the event of those of us who do not believe in an influenza vaccine, how is it that we can first recognize if there is a need to be alarmed, and what is the best method of treatment in the case of us if we have not been vaccinated? We also look at the common upper respiratory tract infections that our children tend to suffer with the chronic sinusitis and the middle ear infections, and how best it is to recognize them and treat them as early as we can. In addition to that, not only are upper respiratory tract infection the only one associated with allergies, there are also skin manifestations, lower respiratory tract manifestations. There are also manifestations that can be life-threatening, and other manifestations can be disgusting if not treated, especially in our kids when we recognize that they suffer with eczema. Do not wait until the child starts to complain that they're scratching their skin for the entire night and unable to sleep, and just use baking soda and soothe the skin. Try and get them to their physician to treat it, because it's such an easy thing to treat in the very early cases. For those of us who recognize that we're allergic to a medication, it is your responsibility, not that of your physician, to know what you're allergic to. Always have with you at your disposal some method of saying to someone that I'm allergic to this particular kind of medication. I will always strongly advise that you have a bracelet that says I'm allergic to, whether it be penicillin or any other form of medication. That basically when you're even in the emergency room, even in a comatose state, someone can recognize that basically this is what you're allergic to. And I'm not just basing this on things that I've read. This actually happened to my sister. So basically I'm telling you from life experiences that there's some common things we should adopt and approaches to life that can sometimes save us. And there's some things that we can do, the regular washing the hands, not sneezing in front of others, taking medications and staying away from others once we have a contagious infection. That can actually result in us not passing on infections as frequently as we do, especially if you're aware that we're infecting others. If you're in a closed environment, in a closed room, whether with others, then try and avoid sneezing in the faces of others or have others sneezing in your face. It's not only the right thing to do, it's also medically and ethically correct that we should not be passing on infections to others, especially when we are aware how contagious it could be.